Good afternoon, everyone. So today we are discussing about Vasiculobullious disease. So I have sent in group the PPT, so you can view that. In that I have sent you can see the layers of different layers of the skin. So in that we need only just epidermis and dermis to discuss about this disease. So the Vasiculobullious disease is basically it is a type of mucocutaneous disease characterized by vesicles and bullae, or we can call blisters. The bullae is also called blisters. Both the vesicles and bullae are fluid-filled lesions, and they are distinguished by the size. So vesicles being less than 5 to 10 mm, and bullae being larger than 5 to 10 mm. So depending upon the definitions, we'll see the different types of vesiculobullous disease. So we know that vesicles are the sacs of fluid-filled space. Okay, so that is called vesicles, and bullae is blisters, fluid-filled blisters. Okay, so you can see here in the second slide there is different layers of skin. So in that you can see the topmost layer is epidermis, and below that there is a dermis. So in between the epidermis and dermis there is a that layer is called basal layer. So why I am discussing that we'll see here. So see, if something happens between the epidermis, then it is called intraepidermal. Okay, and if something happens between epidermis and dermis, it is called subepidermal or below epidermis. So we can see different types of vesiculobullous disease here: pemphigus, pemphigoid, dermatitis herpetiformis, porphyria cutanea tarda. So among them, like pemphigus is divided into 4 types. That is pemphigus vulgaris, pemphigus foliaceus, IgA pemphigus, and paraneoplastic pemphigus. So among these 4 types, pemphigus vulgaris is the most common one. So we will discuss about this. And then in pemphigoid vesiculobullous disease, that is divided into 2 parts. That is bullous pemphigoid and mucous membrane pemphigoid. So among that, bullous pemphigoid is the most common. So while I was in derma department, I saw these 2 cases. Before that also I saw these 2 cases only, and rest all were not there. So one is pemphigus vulgaris of pemphigus type, and other is bullous pemphigoid. Okay. So we'll discuss about that only then. Then we'll start with the pemphigus vulgaris. So pemphigus vulgaris and bullous pemphigoid both are autoimmune disease. So etiology of pemphigus vulgaris is autoimmune, and then it can also be drug induced. So drugs like penicillamine, AC inhibitor, ARVs, and then cephalosporin. So these are the drugs which can cause pemphigus vulgaris. And then if you see the epidemiology, so when we will see the patient that both the bullous look same. Okay, by physical examination when we will do, the bullous looks same, but how to distinguish between pemphigus and bullous pemphigoid? So these are the things. One is like age, that pemphigus vulgaris will the patient of age between 30 to 60, only the pemphigus vulgaris will occur, and then bullous pemphigoid will occur in the patient more than 80 years old, so old age patients. So and then pathogenesis, if you will see, and then pemphigus vulgaris, you can see, it most common in Jewish and Indian descent, Indian descent patients in persons. So and then pathogenesis, you will see. I told both are autoimmune. So antibodies, it will attack on some cells. Okay. So in pemphigus vulgaris, the antibody, it will attack on desmosomes. So desmosomes are it is the you can say the protein which connects 2 different cells. So we are talking about skin. So skin, what will be there? Keratinocytes. Okay. So so antibody, it will attack the desmosomes. So there are 2 types of desmosomes on which the antibody attacks, that is desmoglein 1 and desmoglein 3. So these desmoglein 1 and desmoglein 3 are the type of protein which connect the keratinocytes. Keratinocytes are the cells of skin. And then acantholysis. So in pemphigus vulgaris there will be acantholysis, but in bullous pemphigoid acantholysis will not be there. So what is acantholysis? Acantholysis are the loose cohesion between the keratinocyte. It means there are the cells of epidermis. In that epidermis cells, the cells are cohesion means attachment. Okay, so there will be loose cohesions means loose attachment between the cells, keratinocytes. And then morphology, if you see the morphology, there are two different types of morphology. One is gross, that is physical, and microscopic. So physically, how we can distinguish or how we can diagnose the pemphigus vulgaris, that is, if you see the bullous of the pemphigus, the bullous will be thin. Okay, the layer of skin will be thin on the bullous will be there, no, so that layer will be very thin. If you push it, it will pop out. So, and then flaccid means it will easily break, easily pop. So Nikolsky signs and Asper-Hansen signs will be positive in pemphigus vulgaris. So you can see here in pemphigus vulgaris, in morphology section, I have given the pictures of Nikolsky sign there. So you can see what's the Nikolsky sign. So Asper-Hansen sign is like when you press the bullous, no, it will spread. The blister will spread from the area of bulle to non-bulle area. And then Nikolsky signs means after popping out, when you press the skin like this, the skin will slide down. Okay, that its skin will separate from the main body. That is called Nikolsky sign. You can see in the picture. And then microscopic is, I told, acantholysis in the intraepidermal bulle, and then loose cells inside the bulle. And then comes to clinical features. So in clinical features, you can see mucous membrane. It means one more distinguishing features between the bullous, pemphigus vulgaris and bullous pemphigoid is that you can see oral lesions in pemphigus vulgaris, but oral lesions and bulle will not be there in bullous pemphigoid. Okay, so what are the different distinguishing characters? One is age, okay, and the second one is acantholysis, and third one is these two signs, Nikolsky sign and Asper-Hansen signs, and fourth one is that oral lesions. It will not be present in bullous pemphigoid. And then blisters develop after, like after the antibody attacks the desmosomes, immediately the blisters will not come. So blisters will develop after few months or weeks. And then treatment we'll see. So treatment is like systemic corticosteroids, that is moderate to high dose of prednisolone is given in pemphigus vulgaris. And then oral pulse methylprednisolone means pulse therapy or pulse IV means intermittent dose. Okay, so intermittent we have to give the methylprednisolone. And then immunosuppressants. Obviously, this is an autoimmune disease, so we are giving immunosuppressants. So what are the immunosuppressants we can give? Azathioprine, cyclophosphamide, and then rituximab. Okay, so this is the most expensive here. So we mostly prefer this one, azathioprine. When I was in OPD, I used to see that doctor used to give azathioprine. And then complications. So after you get after someone get pemphigus vulgaris, so these are the complications which can be seen in later stages. So the secondary infections to bacteria, and then fungal infections, that is candida, can be seen, and then viral infections. So what are the viral infections? Herpes simplex. So and then complications of long-term corticosteroid use. So suppose one patient came with pemphigus vulgaris and you are giving corticosteroids, suppose methylprednisolone or prednisolone. Then after that what will happen? The patient after using, because this pemphigus vulgaris is like you can't cure permanently, okay, so you have to continue with the steroid. So after you are giving steroids for the long time, there are different complications with corticosteroid also, which you can see in the patients. So what are the different complications you can see after corticosteroid long term use is, one is osteoporosis, and then joint necrosis also you can see, okay, and then hyperlipidemia and all. So yeah, and then comes to bullous pemphigoid. So etiology is same, autoimmune, and the thing is pemphigus vulgaris can be disease induced, drug induced, but bullous pemphigoid is not drug induced. And then some complications, and then if the persons have psoriasis, they can also get bullous pemphigoid. And then malignancy means cancer or malignant cancer cell, and HLA, human leukocyte antigen. And epidemiology, old age, and pemphigus vulgaris is like mostly it will occur in female, depending on the region. It's not known that female will get more everywhere. Some region female will get more, another region both will be same. So like that, but mostly most of the studies has seen that female are getting more. Reasons are not known. And then epidemiology for bullous pemphigoid, both and male and female have same ratios. And then pathogenesis, antibody against basal layer. I told no, there is a layer between epidermis and dermis, so that layer is affected. So antibody will attack that layer, and there will inflammation in that layer. So after that, the subepidermal layer will be destroyed, and then there is a dissociation between dermis and epidermis layer, which leads to blisters. And then morphology, same, gross and microscopic. Gross is like epidermis and dermis separations. So there will be separation between the dermis and epidermis because of the blister formation. Okay, if you see the, I have so large tensed subepidermal blisters will be there in this one. So it means tense means hardest, it means hard type, like if you press, no, it will not break easily. But in pemphigus vulgaris, if you press, it will pop out. And then if you it will be tensed, means it will not spread. When you press that, it will not spread. So who is in OPD? Neha, you can see there. So if the physical examination, you can see there. Okay. And then microscopic is like no acantholysis. And then clinical features are eczematous type of that area where the bullous will be there, no, that will have eczematous reaction. Eczematous means eczema formation. And then urticaria like rashes. Urticaria is like mosquito, when it will bite, no, that rashes will come, no, like that. And then treatment. So yeah, ultra potent topical steroids for localized lesions. So when patients will come with the complaints of these things, and they are diagnosed with pemphigus, bullous pemphigoid, they are given with ultra potent topical steroids. Ultra potent topical steroids means ultra potent corticosteroid cream. Okay. So one is like I have seen is they will give betamethasone dipropionate, that is ultra potent, high potency. And then systemic steroids means same, prednisolone. And then tetracycline antibiotics will be given, because this doxycycline will have anti-inflammatory reactions also. Okay. And then antibiotics secondary to bacterial infections. So you can see some complications are there in bullous pemphigoid, that is staphylococcus or streptococcus skin infection. So if the patient is having this type of reactions or this type of sepsis, so you can give antibiotic for that infection. Okay. Okay. Thank you.